A smaller wound near an eyelid, nostril, or lip can be more complex than a broad, shallow wound because function matters more than surface area. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified, Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Hold on a second, wait. If a wound is really that small, why not just stitch it closed right away and be done with it? Right, well, it's a super common question, but surface measurements alone simply do not tell the whole story. I mean, a ruler doesn't show you the depth of the wound, it doesn't show you the missing structural support or how the tissue actually moves. So imagine a broad, shallow wound on your cheek. Because cheek skin is relatively mobile, you can usually just bring those edges together direct to. But now, take a much smaller wound right on the rim of a nostril or the delicate edge of an eyelid. If you just pull that skin tightly together with stitches, you introduce tension. And that tension, it will physically pull and severely distort those highly vulnerable functional landmarks. You literally risk altering how an eyelid blinks or a lip moves. So the true complexity of a repair depends heavily on missing tissue layers, the blood supply, the patient's overall health, and exactly how tension will impact that functional anatomy, not just on what a ruler says about the surface area. And this brings us to an absolutely crucial foundational rule of reconstruction. Definitive design must follow complete cancer clearance. Reconstructive planning might start before surgery, sure, but you have to actually remove the tumor and map the complete margins, which, by the way, is exactly what Mohs surgery allows you to do. And only then can you inspect and truly understand the three-dimensional wound. You never, ever want to execute a major tissue rearrangement over an incompletely assessed margin. Think about it. If you move a massive flap of tissue over a wound that still harbors cancer cells, you're literally burying that tumor. And doing that makes treating it later incredibly difficult and downright dangerous. The true defect has to dictate the final design. No exceptions. Okay, so if we can't just stretch the skin over that eyelid wound, what exactly is a local flap? Like, how does it actually fix that tension problem? Great question. So a local flap essentially involves recruiting nearby skin and moving it into the surgical wound, but doing so while carefully preserving its original connection to its blood supply. It's kind of like moving a living jigsaw puzzle piece. And it solves a couple of major problems all at once. First off, nearby skin offers a fantastic match in terms of color, texture, thickness, even sun exposure, so aesthetically speaking, it blends in seamlessly. Second, the incredibly careful geometric design of the flap incisions allows the surgeon to redirect tension entirely away from those high-stakes anatomic landmarks we just talked about. But, the design has to be flawless. It absolutely must respect the vascular supply, because if a flap is designed too tight, if it's too thin for its task, or if it's forced across unfavorable older scars, well, it can compromise that vital blood connection, leading to severe healing problems. Now, we need to be clear here. A large flap is just one specific tool. It's not some kind of quality score indicating you got the best surgery. Complexity really has to earn its keep, right? The best repair is always going to be the least burdensome option that reliably protects function and contour. So let's consider the alternatives for a second. A direct closure brings mobile edges together, but the trade-off there is that the scar line might actually be longer than the original wound, just to distribute the tension. Then you have a skin graft. That covers a surface without requiring extensive movement of nearby tissue, but its color and contour might end up looking a bit like a patch. Or there's second intention, which is just natural healing. That uses the body's own filling and resurfacing, completely avoiding surgery, but it requires much longer visible healing, and the resulting contraction can still pull on nearby structures. You could also utilize staged flaps, or even delayed reconstruction, to allow for better graft back preparation. The point is, every single option solves a specific problem, and every single option carries an important trade-off. So, if these complex flaps are so intricate and have all these variables, why do them in an office? Shouldn't I be in a hospital for something like this? Well, here is a reality check based on some really recent data. 16.1%. A 2025 academic cohort actually looked at 436 large post-Mohs repairs performed right in the outpatient setting under local anesthesia, and they found that absolutely no adverse effects were attributed to the local anesthetic itself. However, the overall complication rate was 16.1%. That exceeded the rate for smaller, more routine repairs. So what's the useful takeaway here? Well, it proves for sure that selected large flaps and complex repairs absolutely are feasible in an outpatient office under local anesthesia. But they are not trivial. They carry real risks that require a highly prepared team that knows exactly how to monitor the patient and jump in to respond to complications. It all comes down to this. The environment must precisely match the patient. An outpatient office is highly appropriate when the patient is medically stable, the repair can be done comfortably with just local anesthesia, and the necessary sterile technique and equipment are ready to go. But let's say that small eyelid wound suddenly requires a cartilage graft, or the patient has severe medical complexities that require general anesthesia or airway support. Well, that completely changes the calculus. In those cases, moving to an ambulatory center, a hospital, or collaborating with another reconstructive specialist becomes completely necessary. Actually, the available observational studies do not prove that one setting is universally superior for every single wound. Claims that one setting is always safer go way beyond what the data actually says. The setting just has to fit the operation and the available rescue resources. Okay, so as a patient then, does seeing a specific specialty label on the door guarantee that I'll get the best result for my wound? Honestly, the evidence says no. There are no controlled studies showing that a specialty label alone determines the best outcome for every wound. Now, fellowship-trained Mohs surgeons certainly have structured experience in tumor removal and reconstruction, while other specialists bring different, highly valuable training and resources to the table. But instead of hunting for a specific label, you need to empower yourself with the right questions. Ask your clinician directly. Do you routinely perform this exact repair? Can you explain the reasonable alternatives and their trade-offs? What exactly would trigger you to change the team, the anesthesia, or the setting? Is there a clear, actionable plan for bleeding, pain, or an unexpected event after I go home? And most crucially, especially for a wound on the lip or eye, will this specific repair protect the functional structure that matters most? Getting the answers to these questions is going to be far more protective for you than relying on a specialty title. All these technical details, the tension, the blood supply, the setting, they all point back to one core philosophy. Mohs surgery and reconstruction belong in one tightly coordinated plan. You clear the tumor, you confirm it's gone by examining the mapped margins, you understand the true three-dimensional defect, and only then do you finalize the design of the flap or graft. The reconstructive operation is never, ever an argument for removing less cancer. It is the exact reason you need to know your margins precisely. The most successful repairs, whether we're talking about a mobile cheek or the delicate rim of a nostril, are built entirely around a confirmed cancer-free defect, not around the initial size of the biopsy scar. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. I highly encourage you to read the complete explainer at skintrust.com to better understand these reconstructive options. And please, use it to guide a direct, individualized conversation with your treating clinician. So the next time you hear a wound is small, ask yourself, what vital structures lie just beneath the surface, and what is the true cost of pulling them tight?